Hello, and welcome to another learning episode of the PJ Pod, brought to you by the Pharmaceutical Journal, the Royal Pharmaceutical Society's official journal. In this episode, part of the August 2024 digital issue, we'll be exploring the recent changes to the NICE and SIGN guidance on the treatment of migraines, and considering how the use of calcitonin gene-related peptide receptor antagonists, or GPANTs, are opening up new options for prescribers and patients.
The vertigo and the nausea is just with me all the time. So when I move, I get up and I go try to walk, I try to drive the car. Just basically any type of movement irritates and aggravates my vestibular system.
This is Kerri Spalding. Kerri has suffered from migraine for over 30 years. After experiencing severe migraine attacks during the COVID-19 pandemic, where access to clinics and support services were closed to her, Kerri started to blog about her experience as a chronic migraine sufferer. She now works closely with the Migraine Trust, supporting the patient community through fundraising, education and advocacy work.
So I suffer with acute vertigo every day. I originally got into helping and supporting my community because my vestibular system really erupted during COVID and the clinics were closed. I had no treatment whatsoever, no support from my headache specialist. Just felt really alone, completely isolated. And I just thought, I cannot be the only one really, really suffering and struggling right now.
And she certainly wasn't. It's estimated that around 10 million people live with migraines across the UK, costing almost £4.4 billion in lost workdays each year. For many years, the medical treatment options for migraine went largely unchanged. Alongside analgesia and non-steroidal anti-inflammatory drugs, or NSAIDs, clinicians had the option to prescribe triptans and antiemetics for acute use. For chronic migraine, a decision could be made to start additional prophylactic treatment depending on the impact the condition was having on the patient's quality of life. While these options have been sufficient for many patients, they don't work for everyone. There are over 33,000 hospital admissions for migraine in England in the year of 2021 to 2022. What these numbers tell us is that there's a significant subgroup of patients who are failing to adequately control their migraine. For this cohort of patients, first-line options may prove to be ineffective, or they find that they stop working relatively quickly.
Some migraine patients can have what we call clear days, whereas some migraine patients that are chronic like me will experience what we call migraine features. So I constantly live with at least 2 or 3 migraine features all the time, 24/7. It's when that kind of baseline, say I'm at a level 3, then if it goes up to a level 5, so I get acute vertigo, a lot of nausea, I have to sit down, I'm really struggling with light. Yeah, it's difficult because when you live with the condition and the migraine symptoms every single day, at what point do I need to take abortive medication? Because I am living with it 24/7. So, yeah, makes it very difficult.
In Kerri's case, management of her symptoms is made more complex by the lack of a clear distinction between acute and chronic migraine, and there's a constant need to balance her use of different medicines. Another limiting factor is the risk of medication overuse headache, a problem which can occur if patients are overusing acute treatments like triptans, combination analgesics or opioids.
And that is a huge problem for chronic migraine patients. Like I said, I can only utilise my pain relief and abortion for 10 days a month.
The question of overuse headache was something I wanted to know more about, and I asked Mathew Garrod, lead pharmacist for neurosciences and specialist pharmacist in migraine at University Hospital Southampton NHS Foundation Trust, to elaborate.
Medication overuse headache is thought to be when you take a pain medication for your headache too much, you get almost like a rebound headache, a medication overuse headache. Now, this can occur usually if you normally have, say, 15 days a month or more of simple analgesics like aspirin, ibuprofen and paracetamol, or more than 10 days a month of triptans. So the advice is usually to try to stick to, say, a maximum twice a week of your acute analgesia or your triptans to prevent the use of medication overuse headache, and I believe triptans are quite bad at causing medication overuse headache. But it's kind of understandable in a way. If you've got a migraine and you kind of want it to go away, triptans are the only things that work. You can see why people would be taking triptans quite frequently. And then, you get caught in a vicious cycle. I see patients sometimes who are taking triptans almost daily because they get their migraines, they take a triptan, they try to stop taking their triptans, and the migraine gets worse and worse and worse, and they start to get extra symptoms, almost like borderline paralysis, tingles, speech starts to go, and to the point where they want to call an ambulance, and then you take a triptan, it goes away. So you can see why people can get caught up in that vicious cycle.
Mathew also explained that the concept of medicine overuse headache is a subject of debate, with some questioning whether it manifests as a secondary disorder caused by excessive use of acute medications, or should rather be thought of as a symptom of a poorly controlled headache. Irrespective of how medicine's overuse headache is defined, for people experiencing chronic migraines, the upshot is they face a situation where they need to carefully limit the amount of acute medicines they use on a weekly and monthly basis, and this means they're sometimes forced to experience migraine attacks without any pain relief. Which is why the introduction in 2020 of calcitonin gene-related peptide antibodies, or CGRP monoclonal antibodies as they're known, marked a significant step forward for migraine treatment. CGRP monoclonal antibodies were the first class of treatments developed specifically for migraine prevention and offered an additional prophylactic option for patients who had failed to benefit from existing options. Then in 2023, NICE and SIGN approved rimegepant for both acute and preventative use. Rimegepant is the first medicine from the gepant class to be made fully available for use in the UK, but there are a range of other drugs working their way through clinical trials and the regulatory approval process. Atogepant has recently received draft approval by NICE for preventative use in England, having also received approval from the Scottish Medicines Consortium in October 2023. As with CGRP monoclonal antibodies, gepant drugs have been developed to specifically target the migraine disease. Here's Mathew again to explain further.
So we have a number of preventative options, monoclonal antibodies, such as arenimab, fremanezumab, galcanezumab, and eptinezumab, already on various formularies. They've been out for a couple of years, but we haven't had really any successful oral options. So rimegepant is one of the kind of new wave of successful oral anti-CGRPs. So these are chemical entities, drugs that target the calcitonin gene-related peptide that is thought to be responsible for causing the headache pain related to migraines. Interestingly, it's used both as a preventative agent and also it has license for acute usage. So it's one drug with two kind of separate indications. So if you're under, say, a specialist clinic, specialist centre, rimegepant 75 milligrams on alternate days would be an option for you for prophylaxis of your migraine. If, for example, you were unable to tolerate any of the subcutaneous or intravenous options, so for example, if you're extremely needle phobic or you had any potential allergic reactions to some previous injections, an oral option like rimegepant would be quite good.
As a first-in-class drug, I wanted to know more about how rimegepant works. Here's Mathew on the mechanism of action.
So obviously the pathophysiology of migraine has not been completely elucidated. There's a lot of theories to do with the different parts of the migraine. So things like cortical spreading depression, that's like an impulse that just wave across the brain, causes a tsunami of different effects, thought to be associated with things like the aura. And studies found that there was a peptide called calcitonin gene-related peptide that's found in the blood, and it's actually found at slightly higher levels in the blood and saliva of patients who suffer with migraines. And when they have a migraine attack, this CGRP, the levels really do increase. It's a pain signaling neuropeptide and a potent vasodilator. What they did was they gave people an infusion of CGRP and it gave them a whacking great headache. So then they turned around and thought, well, if we block this CGRP, what's this going to do? And lo and behold, blocking the CGRP seemed to reduce people's headaches, people's migraines. So how it works is you've got the trigeminal nerve, and then sort of the calcitonin gene-related peptide comes out of the nerve crossing the synaptic cleft, and then it normally binds to the CGRP receptor. And then you've got various little cascade where you get cyclic AMP, joins with protein kinase A, and then you have vasodilation, and then you end up with the headache pain. So when the CGRP obviously leaves the nerve and crosses the synaptic cleft, you can either block the CGRP molecule itself, so you can have, say, like an antibody that binds to the CGRP molecule, or you can block the receptor, so you can block the ligand or block the anti-CGRP receptor. So erenumab and also rimegepant, drugs that block the anti-CGRP receptor, and the other drugs, so fremonezumab, galcanezumab and eptinezumab, block the antibody itself, so stopping the drug from binding to the receptor and then stopping all this vasodilation and headache pain.
As mentioned, the risk of medicine overuse headache has a significant bearing on how patients manage acute migraine, and this is an area where gepants could potentially open up new options for patients.
So one advantage of the gepants, the new wave, is that there's no evidence that they cause medication overuse headache. So obviously they work in a completely different way. They're very specific to the CGRP receptor. And yeah, I think they've done lots of trials on thousands of patients, and there's no evidence thus far that they cause medication overuse headache at all. So hopefully if you use it as an acute usage, you won't get trapped in that vicious cycle of having it too much and causing headaches.
Another notable benefit of rimegepant is that it's administered orally.
So the rimegepant is an oral iofisylate, so dissolves on or under the tongue, no need for water. So there are going to be sort of advantages for that. So it's quite portable, patient compliance as well. People don't mind taking a tablet. So from a patient tolerability, compliance perspective, an oral option would seem to be better. You could argue that there's less strain on the infrastructure of the NHS. So, for example, if the patient was going to have eptinezumab, which is an intravenous infusion, they would obviously need to come into hospital, maybe as a day case appointment, maybe half an hour, they have an intravenous infusion, and they go away. The intravenous is only every 3 months, but it still means you've got to come into hospital, have an outpatient appointment. Another thing is that you can't really push that into primary care. So if you're trying to keep down your hospital waiting lists, if you're trying to give patient care closer to their homes, that's easier for them. They don't have to come to hospital, take time out of work, they don't have to pay for parking, things like that. Whereas if you've got an oral option, which I believe a lot of trusts are looking at making amber on their formularies, so they're going to be started in secondary care using the preventative agent. They'll be started in secondary care, and then maybe once the patient is stabilised, look at transferring them over to primary care.
Providing treatment options that don't require injections can enable migraine patients to be treated closer to home or potentially self-administer their medicines, leading to meaningful benefits. This is something Kerri has first-hand experience with.
Up until the COVID pandemic, I was receiving 3 monthly Botox injections. I actually had 42 injections in the head, the face, the neck, the shoulders. They were incredibly painful, and it was incredibly hard during my migraine attacks to attend the clinics. So then when the injectable CGRPs came out, I was really keen to get those. One, because it actually targets the migraine disease, but also secondly, I actually get to inject at home, so I don't have to go into the clinic. So when I'm acutely in chronic migraine attack in bed, it doesn't matter because I don't have to leave the house. I can inject myself at home.
For Kerri, the side effects that she experiences from injections have a real impact on how she manages her condition.
Your triptans are the ones that you take when you get an onset of a migraine. So for that, I do a nasal spray and I also do an injection. The nasal spray, sometimes I can get away with here and there, but it's only really the injection, sumatriptan, that really helps. But the sumatriptan injection, it's not something I can take when I'm out. So if I get an attack come on when I'm out and about, I literally have to be in bed because it just causes a lot of side effects. I get muscle weakness with it. I get the nausea that's extra. Usually after I inject, I am going to be sick. So it's not like I can take it in the middle of a supermarket. So it depends where you are, what situation you're in, as to what medications you can take at the time.
As a first-in-class drug, I wanted to know whether there are any patient safety concerns or contraindications that pharmacists should be mindful of as prescriptions for rimegepant gradually start to increase.
Now, obviously, rimegepant and the gepants and CGRPs are quite new, so they're under still their post-marketing surveillance. And it should be noted that patients with heart attacks and strokes within the last 6 months were excluded from a lot of the trials. So you can't say for definite that it's safe in heart attacks and strokes, at least if you've had it in the last 6 months. But after that, then it's kind of more of a clinical decision, clinical evaluation, because I think there's evidence that the CGRPs, they don't cause the vasoconstriction that the triptans do. So hopefully they'd be less likely to be in problem in stroke and heart attack. But I went to the European Headache Federation conference recently, and there was some work, I think lab-based work, so I'm not quite sure how much of it's theoretical, that although the CGRPs don't cause vasoconstriction, they prevent vasodilation, which your body obviously sometimes needs to kind of reduce blood pressure and things. So there might be some post-marketing things that come out eventually about gepants and recommendations and the anti-CGRPs post-stroke and heart attack, but at the moment, there's no evidence to say you can't use them in heart attacks and strokes for patients who've had those more than 6 months ago.
So the evidence suggests that these new treatment options have the potential to make a real difference to the subgroup of patients who experience the most severe forms of migraine. But as with most new drugs, implementation is likely to be gradual. For patients like Kerri, access to new treatments is a live issue, and she was recently informed that she isn't currently eligible to receive rimegepant through the NHS, as she is already receiving a monoclonal antibody for preventative use.
I have looked into accessing it privately. The only problem with that is you've got a lot of online pharmacies that are willing to subscribe it, but I'm not medically trained myself. I don't know enough about the interactions of these new medications alongside my Angivy. I believe in the US they are combining the injectable CGRPs alongside the oral type gepants for abortive medications, but I believe it's not been approved here in the UK. So I'm just kind of nervous, I don't want to go against kind of like the guidelines against my neurologist either, and do something even though potentially I could gain access to it privately. So that's essentially where I'm at. But for me, to gain access to these oral gepants would be amazing because they don't cause medication overuse. Like I said, I can only utilize my pain relief and abortion for 10 days a month, whereas the oral gepants, the oral CGRPs, they don't have that issue. Patients can use them daily for abortive medication and preventative. So that's kind of where my mindset goes in order to help me as a chronic migraine patient. It would be great, knowing that I have 10, 15, 20 days a month of pain where I can go over those 10 days a month. All I would like to do is just be able to work. At the moment, I only work 1 day a week. I'm not able to work any more than that. And, the financial crisis that we're in right now, I need to be working more. I need to be healthy. I want to be able to work and, help subsidise my family and my income.
Responses to a Freedom of Information request by the Migraine Trust in February 2023 show that new CGRP medicines are not available in all trusts and health boards. And as CGRP treatments need to be prescribed by a secondary care specialist, even where they are available, people are facing increasingly long waiting lists to access appointments. With rimegepant now available within the NHS, I asked Mathew if he thought patients were likely to be managed from specialist settings or from primary care going forward.
Again, you have to kind of split it up into the preventative and the acute treatment, and these are initially being managed differently. So at least in our area, and I think a lot of other areas, the preventative treatment option, which is 75 milligrams on alternate days, that's being very much managed in the kind of specialist area, so in your specialist headache clinics or your neurology clinics. But with potentially an eye to, after 12 months, 15 months, or whatever the local formulary says, to push that back into primary care. But the acute indication, so for people who can't tolerate or have been non-responsive to triptans, we feel that the best place for that is in primary care just straight away. Because obviously primary care, the GPs are where patients come for their headaches, their migraines. Their GPs get them triptans, and they're very well versed in dealing with headaches and migraines. And if a triptan doesn't work, having a rimegepant as an option, it's 75 milligrams as needed for your kind of headache or migraine, maximum 1 tablet per day. It's very well suited for being in primary care. So we very much see rimegepant green on the formulary, so just for PRN usage, just straight into primary care. So I think there's been a lot of work at the moment with local GPs just trying to go out and speak to them and say, this is on the horizon, this is the acute treatment, this might just be coming straight to you, and then preventative will keep with us for a little while, get patients settled, and then eventually come to you as well.
With the treatment landscape for migraine changing quickly, there is clearly a major role for pharmacists to play in diagnosis and management, and in helping patients access the right services through effective signposting and referral. As a migraine specialist pharmacist, Mathew shared his thoughts on the value pharmacy teams can add.
I think if I talk sort of secondary care, sort of my setting first of all, I think, pharmacists I think are a really good place to help. So obviously pharmacists in general, they come with quite a wide skill set that tends to be quite different from nurses and doctors. So it's good to kind of almost like kind of slot into the team and add a different set of skills. So from my perspective of secondary care, joining a headache team was a really, really good step. I think I've become quite a good part of the team. So part of my role is we have joint kind of clinics with the consultant neurologist. They have headache clinics, in which case I sit in there as well. So the consultant kind of runs a clinic pretty much on the diagnosis side of things. And then I'm there kind of to help and supplement any sort of drug-related queries or just any kind of logistical things and challenges. And then, so the patient gets their prescription. I'm normally the one who's screening the prescription, sorting out any things with the home care, stock supply, dosing, checking there's no interactions or anything like that. Just double checking various other parameters like your bloods, liver and kidneys. And then I also am lucky enough to actually have my own anti-CGRP clinics. So when the patients go away with their prescriptions, they get 3 months, then they come to me and I review them. So I go through their headache diaries to see how the treatment's been working. I talk to them, ask if they have any problems with any side effects, how do they feel it's gone, if they noticed any changes in their migraines, has the pain got better, worse, has the severity or the duration of the headaches got better or worse, have they noticed any changes in the extra symptoms. And then I type up my clinic notes, send that to the patient and the GP, and then I'm also managing the sort of the prescription supply and ongoing reviews. And then if any patient sort of queries come in, they normally get tasked either to the consultant or myself, and then I can, pick the ones that are appropriate for me and answer them and leave the ones for the consultant. So you get to be a good part of the MDT.
One other important consideration that came out of my conversation with Kerri was the need to think holistically about migraine and the importance of effective collaboration between services.
Yeah, so my migraine management under my general practice, my GP, it's, I'd say 50% have been really positive, but I've also come up with a lot of challenges and a lot of barriers. So for women particularly, migraine disease is hugely affected by our hormones. I find that GPs initially, they're very keen to start you on preventative medication. When that fails and you've failed 3 medications, you then are referred on to neurology. But neurology only treats one part of the migraine. For us women, we suffer fluctuations with our hormones. So I suffered menstrual migraines so acutely, I potentially would wipe out 2 weeks every single month in bed, unable to function. And it probably took me 6 years to get my GP practice to refer me to gynecology. So I think for me, working with my GPs, it's been a case of I've had to really fight and advocate for other referrals. With my vestibular system, I've also needed an ENT referral, and I've had a lot of ENT work done where they have found certain things that has affected my vestibular system as well. So I kind of call it like treating a migraine patient like an onion. Okay, so you've got a multi-layer function going on with migraine disease. It affects the whole body. It's not just neurology where we need referrals. It's ENTs, it's rehabilitation, depression, anxiety comes into a lot of it. So, just therapy in general for anxiety, depression, because we can't take those types of medications because it erupts us. Gynecology for women is just, to me, is like so important. So whilst I've had good positive experience, it's also been really challenging, and I've really had to fight and advocate. And in the end, I finally got my referral, and I'm now getting help through the gynecologist, which has really, again, had a positive impact on managing my migraine. But it took 6 years to get that referral.
There are also significant benefits from non-pharmacological approaches. Kerri, for example, has found cold water therapy to be an effective alternative to acute medicines.
I have actually just started a new therapy, which is cold plunge bathing. And I'm actually using that because my abortive medication runs out. I go past my 10 days. I'm left unable to take pain relief or any kind of migraine abortive medication. So the ice bathing is actually reducing the amount of abortive medication that I'm using. So it's really helping reducing the amount of sumatriptan sprays I'm using and the amount of ibuprofen I'm using.
So what else is on the horizon for migraine treatment, and what should pharmacists be looking to do next?
So I'd say as far as the future goes, I think you're going to see more dynamic treatment options. So you've seen it initially with Rimegepant, where people have it as a preventative agent or as an as needed, in a similar way to when you have Foster inhalers for your kind of symptomatic and reliever therapy. You have 2 puffs twice a day and then as needed. If you kind of think of it like that, it does make a bit of sense. So I think we're going to get some dynamic prescribing in that respect. Yeah, there are questions around what goes to primary care and what stays in secondary care, and you do wonder at what point some of the injectable options, if they are relatively, safe and relatively well tolerated by patients, the patients who are injecting them themselves, you do question what the benefit of keeping some of those drugs in secondary care is from a clinical perspective. Obviously, it's a bit different to say insulin diabetics, but patients in the community, they get insulin injections and needles and things from their community pharmacy. They inject them themselves. So I'm not sure what added clinical benefit keeping some of the injectables in secondary care is, but I think that's a bigger discussion to be had.
So clearly cause for optimism. The rapid emergence of new treatment options has the potential to significantly reduce the massive burden imposed by migraines nationally. And it's hard to understate how significant it is for patients who are suddenly able to successfully control their condition.
When I phone up and I speak to patients, they genuinely say things like, "This has been life-changing for me, and this has been brilliant." And I don't know how many other sort of areas of medicine, healthcare you really get where patients go, "This has changed my life." I think, it's about like 1 in 4 people have migraine in the UK, age 15 to 49. It's like the 3rd most common health condition in the world. And more people live with migraine than diabetes, asthma and epilepsy combined. You're 2 to 5 times more likely to have sort of anxiety and depression if you have in migraine patients than the general population. And that's a lot. It's not just a headache, it's just it's affecting all of your life, all your relationships, your work. And it's just, if you could just say have an effective treatment that just gives you a few days back, some people seem to be absolutely so grateful. I think it's definitely rewarding, and it's really good to, when you speak to the patients and they say it's worked, it's brilliant, and it kind of makes you feel quite relieved that we're doing something that actually helps.
So to recap, we've heard about how new treatments are beginning to change the way migraine can be managed. We've also touched on some of the ways pharmacists can help to improve patient experiences of migraine. While recent medical advances look promising, it's undeniable that there are still significant unmet clinical needs, with access to specialist services and the newer medications varying across the UK. With patients often using their pharmacy as the first point of contact for management of acute pain and headache, there is a lot that pharmacists can do to help people understand the symptoms they may be experiencing and support patients in gaining access to the right services. As we look to the future and increasing levels of pharmacist prescribing, it is not hard to imagine a growing role in the diagnosis and management of migraine, with pharmacists using their expert knowledge of medicines to full effect. And that's where we'll leave it today. You can find links to relevant PJ articles, available guidelines and further resources, including national pathways and toolkits on migraine, in the show notes. Our thanks go out to Mathew and Kerri for their contributions, and of course to you for listening. Until next time, bye-bye.